later. A little bit about the symptoms of gastro. So the main two ones that you want to know about are the nausea and vomiting and diarrhea. So usually for your viral gastro, the diarrhea tends to be watery and profuse. That is in contrast to your bacterial diarrhea, which tends to have bloody stools and high fevers. Now, in your OSCEs, it might also be nice to ask about things like sick contacts or recent travel. Now, does anyone know what specific sort of stuff that we look for on exams for gastro? Good, very good. So fantastic. So the main thing we want to focus on is dehydration, because it's dehydration that really kills children in developing countries with gastro. And the signs of dehydration and volume depletion I've sort of listed over here. So that's your tachycardia, tachypnea, hypertension, dry mucous membranes, altered mental state. There's a bunch of others, but I recommend familiarizing yourself with them just for OSCEs and before exams. Now, in terms of the investigation, the diagnosis is mostly clinical. So for most cases, you don't need a stool sample at all. You only would consider a stool sample if the diarrhea was bloody or mucousy, or if it's lasting more than 10 days, or if the child is very unwell. So, if they're septic or if they're immunocompromised. Otherwise, you don't need a stool sample. For the management, as you guys pointed out, dehydration is a big concern. So for the management of gastro, it's all about hydration, hydration, and hydration. So the first thing that you can try is your oral hydration solution. So what's commonly given in hospitals or clinics is your Gastrolite or your Hydrolite. So these are usually, so oral hydration solution is usually used for more patients with more mild gastro. So your routine gastro, where they just have a little bit of diarrhea and then they self-resolve. So that's where you can sort of manage them as outpatients and just have them take a bit of oral hydration solution. Now, for patients with more moderate dehydration, so I'm talking about patients who are more irritable or lethargic or have slightly deranged vitals, these are the ones that you're concerned about and you want to admit to hospital. And when you bring them into hospital, the first thing that usually the first line hydration option that you want to go with is your NGT hydration. And that is preferred before IV because NGT is more effective and better tolerated. Now, you can also consider jumping straight to IV, but that is only sort of indicated for cases of severe dehydration or shock. So essentially, if they have marked hypertension or tachycardia, so in that case, you would consider IV hydration first line. Otherwise, if they're outpatient, you can manage them orally at home. If they're moderately dehydrated, you can use nasal gastric tube. And yeah, if they're severe, you use IV. Now, another drug that you can use is ondansetron. And that's only for children who are more than 6 months old. And the main thing with management regardless is hydration. So I want you guys to take away hydration from this. And for the complications of gastro, you can get metabolic acidosis. And I've seen Monash ask about this in past questions. And the reason why you get metabolic acidosis is when you are having those diarrhea, you are also pulling out some of your bicarbonate ions, which oppose the acids. So as a result, you get metabolic acidosis from dehydration. Now, some patients also get transient lactose intolerance. Now, I have a few Asian friends who actually do have lactose intolerance and they can't eat ice cream, which is pretty sad. But the main reason why they have these symptoms is because they lack this enzyme called, I think, something like lactase dehydrogenase or something similar to that. And essentially, if they don't have that enzyme, they can't break down lactose. And the reason why some patients got transient lactose intolerance after gastro is because when they have that diarrhea, they are also pulling out some of that lactose intolerance. Sorry, pulling out some of that lactate. And as a result, they get transient lactose intolerance. So I've just got a question in the chat. So can you get alkalosis from vomiting out hydrochloric acid? So yes, absolutely. And that's a very, very good point and caveat. So the thing with gastro, it really sort of depends because on the one hand, you can vomit out stuff and lose acids, But on the other hand, if you get severely dehydrated and you go into shock and stuff like that, that's when you see your metabolic acidosis. Now, in general, from my experience with past Monash exams, they tend to prefer you putting metabolic acidosis because I'm assuming maybe in more severe cases that outweighs the alkalosis that you get from vomiting out acids. But that is a very good question, and you're right. You can get a little bit of alkalosis, but overall, in exam questions, I would put metabolic acidosis. I hope that answers the questions. And yeah, someone asked me, why did I get acidosis again? So there's a few mechanisms. The one that I like to remember is that when you are having diarrhea, you pull out the bicarbonate ions, and bicarbonate is a base. So essentially you're pulling out the base, so you get more acid. Does that make sense? Great, cool. So I got a quick question here for everyone. So take a look at this and let me know what you think. I'll give everyone 10 more seconds. Yeah. So this is a tricky question. Yeah. All right, cool. So the answer to this question is B, NGT rehydration. This is a tricky one, and I got it wrong. I got it wrong the first go. And the main thing that you need to keep in mind is to sort of identify which state, how dehydrated they are. So I pulled this table from the RCH. Now, I sometimes have the memory of a goldfish, so I don't bother remembering all these things. What I like to look at is the first three columns, which I've put in this red box. So if you compare the first column between mild, moderate, and shock, in patients with mild dehydration, they are alert and responsive. In patients with moderate, they are lethargic and irritable. And in shock, as you would expect, they have reduced conscious state. And if you look at the vitals, so normal for mild, mild tachycardia for moderate, and I'm assuming moderately tachycardic for severe. So essentially, those are the things that help you tell what's mild from what's moderate from what's severe. So if you look at this stem, the key things that point out that this is moderate for me is that the child is irritable and the lethargic. Additionally, her vitals is, her pulse is 110, normal is 100. So oral. Hello, did I cut out for a bit?
Yeah, you
Sorry
cut
about
out
that.
a bit.
Yeah, my share house is really shit internet, unfortunately. But let me get back to sharing my screen. All right, can everyone see that again? Fantastic. Thank you. All right, so I'm not sure where I cut off, but just to summarize, if they're mild and they're alert and responsive, you give them oral hydration. If they're moderate and they are lethargic, irritable, and they have mild tachycardia, you give them NGT and admit them into hospital. If they are shocked, then that's when you jump straight to IV hydration. I hope that makes sense. Yeah. Cool. So now, moving on to our next condition, why don't you guys take a look at the stem and then PM me the answers? I'll give everyone 10 more seconds. Good. So again, this is a tricky question. I only pulled out the tricky question for gastro because I feel like the other ones are pretty easy. But with this question, it's actually talking about lactose intolerance. So remember how I talked about when you have diarrhea, you also pull out some of that enzyme which processes lactate. That's what happens here. And essentially, the reason why it's not celiac or IBD is because for those diseases, the diarrhea is more protracted. It's also unlikely to be a secondary bacterial infection because there's no signs of a fever or any atypical sort of diarrhea. And also C. difficile is unlikely, mainly because antibiotics, you don't use antibiotics to manage viral gastroenteritis. So the answer for this question is lactose intolerance. So this is a hard one. So so I'll just put this just to show everyone what could potentially happen. And now to our next condition. So take a look at this, Dan, and see if you can give me a spot diagnosis. Good. Great. Fantastic. So the majority of students said GOR, and that is what this is. So this is gastroesophageal reflux. So we're going to be talking about GORD. So GORD typically occurs in a young child that's less than 6 months, and it peaks at around 4 months. So anything beyond 6 months or 1 year, you really want to think about something else. And when thinking about GORD, it's important to distinguish what's normal from what's abnormal. So GOR, or gastroesophageal reflux, is benign. And that's essentially just reflux of your food contents, which leads to vomiting. Now, this is normal because in children, if you look at their esophagus, it is much shorter compared to an adult. And also, combined with the fact that they are lying down all the time and they're eating a liquid diet, they are much more likely to vomit. And for normal children, this occurs several times a day. The management for GOR is just to reassure the mother. In contrast, GORD is the symptoms of GOR plus more concerning signs. So these symptoms include significant irritability, food aversion, failure to thrive, so they're not meeting their growth centiles, and also respiratory symptoms, so a cough from aspiration. So with these symptoms, you would think about GORD as opposed to benign GOR. Now, GORD itself is a clinical diagnosis. You also want to think about other differentials, such as a food allergy. So for food allergy, you might notice some allergic symptoms, such as eczema or a rash. Additionally, you want to think about pyloric stenosis as a differential. And can someone remind me of the hallmark symptom for pyloric stenosis? Good. Yep, projectile vomiting. So much more violent vomiting. And also for your gastro, you get your diarrhea on top of the vomiting. So that's the key differentiating feature. Now, to manage GORD, the first line medical management is your omeprazole. So you can also use ranitidine as an alternative. But when I did a little bit of digging on the guidelines, I found that omeprazole was more commonly recommended as first line. And in your OSCEs, it would also be good to talk about things like ensure they're not being overfed or that they have good positioning. Good. So now take a look at this question and let me know what you guys think. Great. I'll give everyone 10 more seconds. Good. Sweet. So the majority of students actually picked F, which was absolutely correct. So in this stem, the child has vomiting, which is normal. And the key thing to note in this stem is that they are well hydrated, afebrile, and following growth centiles. Those are all the words that the examiner puts in to push you away from GORD and recognize that this is normal. So the correct answer for this question is no investigations required because it is normal. So good stuff. Now for our next condition, this is a past exam question. So not the image though, but take a look at the stem and see if you can give me a spot diagnosis. That was fast. Yeah. Good, good. All right. So this condition is your classic celiac disease. And what celiac disease is an autoimmune disease triggered by gluten peptides. So your gluten are your wheat, your rye, your barley. And typically it presents in Monash land, at least, with a 2 to 4 year old child with chronic diarrhea and weight loss. And on examination, you also notice abdominal distension and also muscle wasting around the buttocks. And the reason why they get muscle wasting is because of the malnutrition as a result of malabsorption due to celiac. Does anyone know the first line investigation for celiac disease? What do we order? First line. Good, antibodies. That's right, someone said antibodies, I like it. Yep, so first line, you want to order anti-TTG. So there's a couple of other ones that you guys might have come across, such as anti-endometrial or anti-gliadin. But the most sensitive and the first line investigation that you want to pick is anti-TTG. You also order that together with a total IgA to rule out IgA deficiency. And in your OSCEs, you might also talk about ruling out your Giardia or your type 1 diabetes. But the takeaway is your anti-TTG first line. So that's your first line thing. But to diagnose celiac, you need an endoscopy and a duodenal biopsy. And if you compare the top, which is normal, and the bottom, which is abnormal, what you see is atrophy of the mucosal folds, as well as this scalloping sort of pattern. So those are the characteristic signs of celiac disease. And to manage it, it's pretty simple, straightforward, strict, lifelong gluten-free diet. Now, for our next condition, we'll be talking about infantile colic. Now, I dug out this classic case of infantile colic just to show you guys, so you guys can take a read. But essentially, it's a child that's crying quite a lot. And yeah, actually, before I go on to infantile colic, just got a question asking me about total IgA. So the reason why we order a total IgA together with anti-TTG is because anti-TTG, so the antibody anti-TTG itself, so it itself is an IgA antibody. So this is literally an IgA antibody. So the reason why you want to order a total IgA is because in 2% of patients with celiac disease, they also have IgA deficiency. So if IgA is low, then your anti-TTG is also going to be low because anti-TTG is an IgA antibody. So in those patients, you wouldn't use anti-TTG, you would use something else, such as anti-endometrial antibody. So that's essentially the the main reason why you always order a total IgA together with anti-TTG. And also someone asked me about endoscopy. Look, I have to say, so the question was, how do you differentiate it from cobblestone appearance in IBD? The answer is, I actually don't know. I think for me, I just look at these images and sometimes it can be a bit confusing, but in my past experience, I've never seen them ask a photo on endoscopy in year 4 Paeds. So hopefully it's not too big of an issue and hopefully there's a clinical science to guide you. But sorry about that, I can't help you with that over there. Cool. Anyways, back to infantile colic. So essentially, it's just a condition caused by excessive crying of unknown cause. It occurs in young children, and it presents as crying lasting a few hours. In the stem, you might also see some maternal anxiety and fatigue. But otherwise, the key thing is that the baby is healthy and thriving. So if they are not, so for example, if they're not meeting their growth centiles and they're vomiting, you want to think about GORD. And another differential is normal behavior. What I mean by this is that, you know, if you have an infant and you take them away from their mother, they're obviously going to be upset. Now that's normal, and that's not infantile colic, because infantile colic is excessive crying of an unknown cause. So this is what I mean by normal behavior and infantile colic. Now, to manage infantile colic, it's conservative. So, you reassure the mom and you try different soothing and feeding techniques. So conservative management. The next condition is encopresis. So encopresis is elimination of feces inappropriate for developmental age. And you can really only diagnose it in patients who are more than 4 years old. The reason is, when a child is young, it's normal for them to pee or poo their pants. That's why we have nappies. So, you can only diagnose it essentially after they're 4 years old. And the number one cause of encopresis is actually constipation. So essentially what happens is, when such a big lump of stool builds up, this rectum becomes so filled up that any further stool that's coming out, there's no place for it to stay. So it simply just leaks out. So as a result, sometimes you get them pulling their pants because they just can't control it. It's just leaking out. And in an exam stem, what I've seen is sometimes they might throw in a psychosocial stressor. So I'm talking about, a child coming in who's pulling their pants and they've recently started school. So that's what I mean by a psychosocial stressor. And in terms of management, you have two avenues. So you have your lifestyle management. So ensuring they go to the toilet regularly so they don't get constipated. And also you have your laxatives. So these include your macrogol and your paraffin oil, which is a lubricant. Good. And now for our next condition, can someone take a guess at what this could be? Yep. Yep. Good. Yes, basically this is a form of parasitic infection. It's pretty much it's worms, but the more specific words for this is actually a threadworm or a pinworm. So this is spread through fecal oral, and it presents as perianal itching at night, which sometimes disrupts the child's sleep. When you examine them, you might notice some white threads in the stool or perianal area, like you see here. And the investigation that we do is something called a tape test. So that's quite crude, actually. It's essentially what you do is you get a tape, you stick it to the perianal region, and you pull it off, and you see if there's any, any threads or any worms on there. Now, to manage this condition, does anyone remember what sort of drugs you use to kill these worms? This is a tricky one. Yes. Yeah, so this is a tricky one. And I can't remember the last time we covered this, but the drug that's commonly used for helminths or worms is your mebendazole and your parental. And the important thing here, as someone excellently mentioned in the comments, is to treat all family members. So mebendazole for everyone. Good. So now for our next condition, have a look at this stem and let me know what you guys think. Good. So everyone's pretty much getting this correct. So the correct answer for this is your stool MCS. And this is actually a case of Giardia. So what you might notice in the stem is that they're from an international adoption agency, which is essentially the examiner trying to tell you that, essentially they're sort of from overseas or they've sort of traveled. And they have intermittent foul-smelling diarrhea. So that's, again, characteristic of Giardia, and they're not meeting their growth centers. So, oh yeah, like for me, I don't know why, but Giardia reminds me of this character from SpongeBob. So I just thought it was pretty funny. But anyways, carrying on. So now I'm going to be talking about the parasitic infections that cause diarrhea. So these include your Giardia. And as I talked about earlier, that's your persistent, greasy, mucousy diarrhea after traveling. Does anyone know the drug that we use to manage metronidazole? Sorry, I gave it away. The drug that you use to manage Giardia is metronidazole. And I've seen quite a few exam questions on this. So I think Rupert Hines really likes his Giardia. The cousin of Giardia is your amoeba. The different thing between amoeba and Giardia is that amoeba has persistent bloody diarrhea as opposed to greasy and mucousy diarrhea. But otherwise, they're both quite similar. They're persistent, and they also come from traveling. And the management for that is metronidazole. And someone asked, is metronidazole an antibacterial? Yes, absolutely. Metronidazole is used commonly to kill your anaerobes, but it is also used to target protozoa, such as Giardia and amoeba. So it can be used for both antibiotics and this. And finally, a worm that I also wanted to talk about is this thing called a giant roundworm. So if you look at how the measurements, it's actually quite big. And essentially, these worms, they migrate into the lungs and trachea via the portal vein, and they present with dry cough, bloody sputum, and diarrhea. So if someone has diarrhea in the stem, and they also have this, let's say bloody cough, then you might want to think about this as a differential. Now, does anyone remember the medication from the previous slide that we used to manage the worms? Good. Good. So mebendazole, that's the one that we use to manage these worms. Fantastic. All right. Now to our next condition. Can you guys give me a spot diagnosis for this one? Good. Good. Very good. Yep. Fantastic. So a few of you guys actually pointed out that this is erythema nodosum, which is absolutely correct. So this is a classic manifestation of IBD, and IBD is an R3 condition this year. So you don't need to know too much about it besides that it is a differential. As you know, you can have UC or Crohn's. It's characterized by both periods of remission and exacerbation. The main symptoms are your abdominal pain and your protracted diarrhea and constipation. So it's not acute usually. You have this long course of diarrhea and constipation. You might also see some weight loss. And for the extraintestinal symptoms, you get some clubbing, mouth ulcers, skin lesions, such as erythema nodosum. And then also an important thing is that the primary sclerosing cholangitis, which is strongly associated with UC, and it presents with jaundice. Protracted, what I mean by protracted is essentially like a persistent or chronic, so not acute diarrhea. So usually when you see patients with IBD, they have like quite a few months of diarrhea. That's what I mean by protracted. And yeah, to investigate, you do an endoscopy and a biopsy. Now, here's another classic stem of a condition. Does anyone know what this could be? Very good. So this is cow's milk protein allergy, and this is the classic stem. You're looking for a child that's very young who has just started formula, and the characteristic signs are the blood and mucus in the stool. They might also have some diarrhea or vomiting, and sometimes they might also have some atopic risk factors or symptoms. So as you see here, the child on the right has some eczema. So in those conditions, you would think about cow's milk protein allergy, and the management for that is to avoid cow's milk. Now, for our final gastro condition, can someone take a look at this and let me know what they think? Good job. Good job. Everyone's on point today. So this is hepatitis. And as many of you pointed out, hepatitis A. So hepatitis is, again, an R3 condition in this year. So I'll talk about it briefly. So hepatitis A, it's spread through food and water. It's characterized by acute jaundice and abdominal pain, commonly after traveling, which is why sometimes we give people hepatitis A vaccines. And the management of that is supportive. So this is acute, in contrast to Hep B and Hep C, which is more chronic. So Hep B is spread through sex and vertical transmission, and Hep C is spread through blood. And a much greater proportion of Hep C progress to chronic. And for both of these conditions, generally they're mostly asymptomatic until liver failure, as opposed to Hep A, which presents more commonly with acute jaundice and abdominal pain. All right. Now, I've just had a question about how CMPA presents differently to lactose intolerance. So the main difference that I would say is that in CMPA, you get blood and mucus in the stools. That's less commonly seen with lactose intolerance. And also, you might also see some, I guess you can also see atopic risk factors and symptoms, but I guess I'd say blood mucus in stools. And then if you're looking at an exam question, what you're looking for is a child that's, I guess, yeah, I think a child that's just started cow's milk, but then again, I guess it could also be lactose intolerance. But yeah, blood and mucus in stool, I'd say that's a big one. I hope that answers your question. And someone asked me again if I could explain again which method we choose for rehydration. So yeah, sure. So I won't go back to the slides because it's quite a while back, but essentially, if it's mildly dehydrated, so if the child is, they aren't really lethargic or irritable, and essentially they don't have any deranged vitals, then those patients, you manage them with oral solution because they have mild dehydration. In patients with moderate dehydrations, the characteristic signs are someone who is lethargic and irritable and have mildly deranged vitals. So those patients, you admit them into hospital and you place them on NGT first. Now, on the third sort of thing, on the other side of things, you have for patients who are severely dehydrated, and I'm talking about things like shock. Those patients typically have reduced conscious state and they have moderately to severe deranged vitals. So in those patients, then you jump straight to IV hydration. Does that make sense? Cool. All right. Sweet. Cool. Let's move on to our second part, which is genital urinary conditions. So we are going to start off by talking about UTIs, which I hope you guys are well familiar with by now. So what UTI is it's a urinary tract infection, and it's most commonly caused by E. coli. And the risk factors are being female and having genital tract abnormalities. The thing with UTI in children is that in younger children, it can present non-specifically. So in those patients who are young, you might see an unexplained fever, you might see lethargy or irritability. They might also have some forefeeding, and in more severe cases, they might have sepsis. So essentially, more non-specific symptoms. In contrast, in children who are older, then you might begin to see your classic lower urinary tract symptoms. So those are your urgency, frequency, and dysuria. Now, if the infection spreads further up into the kidneys, it becomes pyelonephritis. Now, can someone tell me the differentiating signs of pyelonephritis apart from cystitis? Good. Fantastic. Yeah. So everyone's pretty much covered the big three, which are the fever, the loin pain, and the vomiting. So those are the ones to keep in mind for an upper urinary tract infection. So to investigate UTIs, the big thing we do is the urine analysis and urine MCS. For urine analysis, we are looking for leukocytes and nitrites. Now, one caveat that to keep in mind is that nitrites is not always elevated in UTIs, especially if the cause of the UTI is a gram-positive bacteria. So if a nitrite is not elevated, it doesn't mean for you to exclude UTIs. So that's important to keep in mind, both for now and as a future clinician. And in terms of urine MCS, so after you do the dipstick, you send it to the labs for an MCS. What you're looking for is greater than 10 to the power of 5 colony-forming units. I've also put a little note here saying that if it's a suprapubic collection, so in other words, if the urine was collected directly from the bladder using a needle, then any growth is a UTI because there's a very low rate of contamination for suprapubic collection. Now, the other thing you want to check for is epithelial cells. Can someone tell me what epithelial cells indicate? Good, yeah. Yes, fantastic. See, I didn't even know this until end of last year, but epithelial cells indicate contamination. So if you see epithelial cells in the future as a doctor, think of that as a contaminated sample of a UTI. So these are the big investigations. The other less routine investigations include your renal ultrasound for those who are seriously unwell or boys who are really, really young. The reason is because you want to do an ultrasound to rule out a urinary tract abnormality, so like a malformation, something like that. And also, you would consider doing a blood culture in those young children because their signs are not specific, and you don't want them to have sepsis. So you do a blood culture just in case if they are less than 4 weeks. All right, onto the management. So the management of UTI is antibiotics. So for your routine UTI, you can manage it with oral cefalexin or trimethoprim. However, if the UTI is more severe, so if they have pyelonephritis, or if the child is very young, then you want to admit them for IV antibiotics. And the antibiotics you give are your benzopenicillin for gram-positives and your gentamicin for gram-negatives. So routine UTI, you can give cefalexin or trimethoprim orally. If it's more severe, admit them and give them IV, benpen and gentamicin. Cool. To our next condition, do you guys want to take a look at the stem and let me know what you guys think? Good. Good. I'll give everyone 10 more seconds. Good. Yep, so it's urinary reflux. And if you can see at this, this is what's called an MCUG, which I will talk about later. But essentially, this is taken while the child is peeing. And you can see a little bit of the dye actually goes up the ureter. So this is taken when the child is peeing, and that's not normal. You don't want the pee to go back in the other direction. So this is VUR or Vesico-Ureteric Reflux. So it's commonly seen in children who are less than 2 years old, so it presents young. And the main thing to keep in mind is that VUR plus UTIs leads to renal scarring. And this is what it looks like. It looks pretty nasty. So usually, if you get VUR by itself, that doesn't cause too much symptoms in most cases, but it is really when you get a UTI, then things get bad and you get renal scarring. So just to drive that point home, for the presenting complaint, patients with VUR are asymptomatic usually until they get a UTI. So once they get a UTI, then they get their classic UTI symptoms that I talked about earlier. And once they do get one UTI, they tend to get recurrent UTIs. So these are the main presenting symptoms for VUR. In terms of investigating VUR, first you want to do a you do a UEC to look for renal damage. Then you want to do imaging, which is where the money is at. So for your first line investigation, you do an ultrasound, and you want to look for hydronephrosis or a dilated ureter. However, an ultrasound by itself is not diagnostic. What you need is a micturating cystourethrogram, or MCUG. So that's used to diagnose VUR. And essentially what happens is you put a little bit of contrast into the bladder, and then you get the child to pee, and you take the x-rays while they pee to see if there's a little bit of reflux back into the kidneys. And for that reason, it's called a micturating cystourethrogram. And finally, you have your DMSA scan. So this is a nuclear imaging study that's used to assess for signs of renal scarring. So just to summarize, first line for VUR is your ultrasound. To diagnose VUR, you use an MCUG. And to follow up and look for signs of renal damage, you use DMSA. I hope that makes sense. And now to the management. So for the first line management, we actually want to give them prophylactic antibiotics. The reason for this is because remember how I said we are worried about reflux combined with a UTI, because it's really UTI that leads to that renal scarring and damage. So for this reason, we want to give them prophylactic antibiotics, so commonly Bactrim, to prevent those UTI from reoccurring. However, if UTIs don't work, or if the reflux is more severe, so I'm talking about grade 4 or grade 5, then you think about surgery. And surgery is a bit more low yield, but I put them here anyway for completion's sake. So there's two operations. You can either have a periureteric injection, which is where you inject a hydrogel, I believe, to close off the angle, or you can reimplant the ureters. But the key thing is, in most cases, you just give them prophylactic antibiotics unless it's severe reflux or if medical management has failed. And in terms of prognosis, most cases resolve spontaneously, which is why you don't need to perform surgery unless it's severe. Now, here's a question. Have a look and let me know what you think. All right, I'll give everyone 10 more seconds. All right, cool. So this is a confusing one. So I took a bit some hard questions for everyone because the Monash ones are pretty basic. But yeah, so essentially the answer for this question is actually A, which is low dose daily antibiotics. Let me talk through why. So the reason is because they have this imaging done, and if you look at it, it's actually not super severe. So I'm going to go back to the grading to show you what grade 3 and grade 4 and grade 5 looks like. So grade 1 is when it doesn't really reflux that much. Grade 2 is when it goes into part of the kidneys. Grade 3 is pretty much most or all of the kidneys. And grade 4 and grade 5, you don't just see a little bit of like reflux, you actually see severely dilated ureters. And if you look at the ureter here, it's quite thin and quite mild. So I mean, not mild, but essentially it's not looking like this or this. So the answer for this question is that this is low dose daily antibiotics as opposed to surgery. Yeah. Cool. And now we have a classic stem here. This is basically, I think you guys all know what this is, but essentially this is nephrotic syndrome, and you're looking for a child with periorbital swelling and also peripheral edema. So the condition we're going to talk about is nephrotic syndrome. Now, I don't know why Monash is obsessed with glomerulonephritis, but they just are. Like, I've seen them do 2 lectures on glomerulonephritis, and every single year, even though I don't think it's a hugely big condition. But anyways, since Monash likes it, we're going to talk about it. So in summary, nephrotic syndrome is characterized by heavy proteinuria, hyperalbuminemia, and edema. What's important to keep in mind is that 90% of nephrotic syndrome are idiopathic or primary. Now, can someone tell me the most common cause of primary, most common cause of primary nephrotic syndrome in children? Good. So everyone, I can see everyone remembers their pathology. So minimal change disease is a big one. So in terms of presenting complaints, patients will come in with generalized edema, so around their eyes and the legs. They might also get some frothy urine, this is what it looks like. Now, sometimes you might see a stem with swelling and some other symptoms. So if they have fever, rash, or joint pain, you want to think about Henoch-Steuern purpura or lupus. If they have macroscopic hematuria, hypertension, or renal impairment, you might think about nephritic syndrome. So those are your sort of atypical presentations. To investigate nephrotic syndrome, you do your urine analysis and MCS. You're looking for a protein that is greater than 3 grams per day and a protein creatinine ratio that is greater than 0.2. You also want to do your UEC. You want to do a LFT plus albumin, and you want to do actually, you don't. Okay, so the renal biopsy, I'll put it in gray because it's a bit tricky. Because in kids, 90% of nephrotic syndrome is actually responsive to steroids. So as a result, if you can treat them to steroids, through steroids, you don't need to perform a renal biopsy, which is quite invasive. So essentially, the takeaway point here is that in children, you don't commonly do renal biopsies unless the diagnosis is unclear or they're not responsive to treatment. Otherwise, you just treat them with steroids and call it idiopathic nephrotic syndrome. Good. So in terms of management, the most important medical management I want you guys to take away is your steroids. So oral steroids, and it is also important to omit them. And to manage their edema, you want to talk about daily weights, strict fluid balance, and your low salt diet. Now, unfortunately, 80% of patients do have a relapse, but when they do relapse, the management is pretty simple. You just reintroduce them on that high dose oral prednisolone. I wanted to briefly touch on the other sort of management for nephrotic syndrome. These are a bit more low yield, but I thought it would be nice to mention anyways. So in some children, they may get very fluid depleted. So I'm talking about to the point of shock. And in those patients, you want to give them fluids. And the reason why they get severely volume depleted is because they lose those proteins, so they don't have that oncotic pressure to hold the fluid in their bloodstream. Patients are also at risk of infection because the proteins that they are peeing out also includes the immunoglobulins and the complements. So in patients who develop ascites or are immunocompromised, you want to consider giving them some antibiotic prophylaxis. For patients with severe edema, so I'm not just talking about the eyes and the feet, I'm talking about edema in the lungs, in the peritoneal space, or if it's so severe that it's causing cellulitis on the skin, then you want to give them furosemide. But otherwise, furosemide is not routine. And also, some patients, when patients are peeing out proteins, they're also peeing out their antithrombin, their protein C, and their protein S. So if patients have a past history of hypercoagulability, you want to give them some anticoagulants as prophylaxis. And I just wanted to mention that the sort of things in these slides, they're not always routine or necessary. The big thing for nephrotic syndrome is your oral steroids. All right, so so someone asked me if all the fluid is getting excreted or going into tissues, why do we give fluid replacement? So the thing is, with nephrotic syndrome is, they're peeing out proteins, so that drags the fluid. So essentially, they don't have much fluid in their actual bloodstream, so in their actual circulation, but they have that fluid in their interstitial tissue, so because of osmosis. So in the actual blood vessels, so their arteries and their veins, because there's very little proteins, they don't have that oncotic pressure, which is why you give them fluids. And would you replace their protein? Yep, sometimes you do give albumin. I didn't include it in this slide because it's more low yield, and the go-to management is definitely steroids. So if you are to give albumin, that's usually reserved for I guess more severe cases, and that's done by actually a renal specialist. And I really don't think Monash will ask about giving albumin. But I'll have a look at that as well so I can get back to you guys later. Anyways, here's a quick question. Have a look and let me know what you guys think. Yep, good. So 5 more seconds. Yep, so the answer is albumin, because that's, albumin, furosemide, those are not routinely used. The main takeaway for nephrotic syndrome is your prednisolone and your midterm and all the other stuff. So that's the most commonly used management option. Now, for the next question, so for the interest of time, I'll skip over this. So this is just essentially this is actually your IgA nephropathy, because the infection is concurrent at the same time as the kidney disease. So For glomerulonephritis, I'll just quickly wrap this up with a few buzzwords. So essentially, with IgA nephritis, you get concurrent infection and renal symptoms. With post-strep, you get infection occurring 1 to 3 weeks ago, together with renal symptoms. With this condition called Alports, you get hearing loss together with renal symptoms. With Wegener's, you get respiratory symptoms, particularly nosebleeds, together with renal symptoms. And finally, with anti-GBM or Goodpaster's disease, you get more general respiratory symptoms. And for our final condition, sorry if I'm going a little bit too fast. Hopefully you guys can take a read in the post slides as well. But enuresis. Enuresis, essentially involuntary elimination of urine inappropriate for age. It commonly occurs, so you can only diagnose it in children older than 5, because any younger than that, maybe they haven't got a chance to gain their bladder control. The main presenting complaint is they pee their pants, and there might be the underlying psychosocial stressor as well. For investigation-wise, you don't really need to investigate it if it's primary. What I mean by that, if they have never gained bladder control at night, then it's called primary, and you don't need to investigate it. But if they have had bladder control before, but all of a sudden they lose it and they have enuresis, then you might do a urine dipstick. And finally, for management, you want to start off with something conservative. So, making sure they go to the toilet regularly. And if that fails, the most successful therapy that you want to go for is this thing called alarm therapy. So this is shown on the left. So essentially what happens is if the child pees their pants, that gives them a little buzz. And eventually over the course of a few months, that sort of trains them essentially, I guess, to control their bladder. So that's the most useful. Yeah. All right. And finally, desmopressin is second line, so you don't need to, you only give it after alarm therapy has failed. So yeah, in summary, we went through gastro and renal conditions today. Thank you for bearing with me. And yeah, I hope you guys do well in the exams.